Welcome to the part 2 of the health information system. So in the previous class we discussed about the health information system as a whole, the key components involved and the basic sources of the health information system. And now we are discussing about the various registers or the sources of health information system. And we have already covered census, registration of vital events, sample registration system SRS, notification of diseases and hospital records. So today we will be discussing about the disease registers. So disease registers are basically classified into two, hospital based and population based. So we have basically two types of disease registers, and these two help to a greater extent to identify um, the list of patients in the defined population who have a particular condition. So it is different from notification where the case is reported and is counted only once. So a register requires that a permanent record be established and that the cases be followed up, and that basis statistical tabulation be prepared both on frequency and on survival. So this is basically done mostly on chronic diseases, chronic conditions where the patients on a register are frequently be the subjects of special studies and they are on track. So when we talk about hospital-based registers, they give access to patient care. It also helps to assess the patient care, participate in clinical research to evaluate the therapy and its effectiveness, provide an idea of the patterns of case, contribute to follow-up of the patients, epidemiological research through case control studies, show time trends in the stage of diagnosis, and they also help study the quality of care for the patients in the hospitals. Whereas in a population-based registry, it contains and track records for people diagnosed with a specific type of disease who reside within a defined geographic region, that is in a community or a city or a state, etc. So the major concern of population-based registries is to calculate the incidence rate. So this population-based registry systematically collects information on all the reportable cases occurring in a particular geographic area during a given period of time from multiple sources. So the comparison and interpretation of the population-based incidence data support population is based on the actions aimed at reducing the burden in that particular community. So these registries can provide data for planning and evaluating the control programs. So in India we have the disease registry. We have National Cancer Registry Program, National Stroke Registry Program, Registry of People with Diabetes in India with young age at the onset, National Center for Disease Information and Research. So ICMR operates the said registries in throughout the country. So we have a good repository of the data. So next is the record linkage. Record linkage means bringing together information that relates to the same individual or family from different data sources. So in this way, it is possible to construct chronological sequences of health events for individuals. The records may originate in different times and places. So medical record linkage implies the gathering and maintenance of one file for an individual in a population with records relating to that person's health. So the events commonly recorded are birth, marriage, death, hospital admission, discharge, sickness, absence from work, prophylactics procedures, use of social services, etc. So why do we need record linkage? Because researchers and the community's demand for detailed statistical information has to be met. In response to the increasing business of health needs, we need more data, uh, improving the data quality and timeliness, introducing the complexity of the data, and reducing respondent burden and cost. So there are some challenges with record linkage, that the volume of data can be accumulated, need for technology, privacy issues are there. You must be aware about the privacy issues that we recently heard during the COVID-19 issues, and also with the discussions and debates that happened with the government of Kerala and some private agencies who were using this data on health records. So, the involvement of different agencies for different health records, high chances of incomplete retrieval of information is there. So, due to these constraints, record linkage is beyond the reach for many developing countries and still a far cry, we should say. Almost all the developed countries are having a well-tracked record linkage services, but it is at its very infant stage or in its toddler stage in countries like India. So leprosy cases surveillance under NLEP, number of children that has been given polio vaccination, JE vaccine, AFP surveillance data under polio eradication, are all these are examples of the record linkage facility system. Then, as I mentioned, the epidemiological surveillance includes the purpose of the surveillance is to keep an eye on the incidence or prevalence and changing pattern of the particular disease so as to adjust the control measures accordingly. As I said earlier, the data under polio eradication is a very good example. So, the number of children given vaccination can be easily identified. So, surveillance systems are set up for selected diseases under the respective control or eradication program as a procedural matter. So these programs have yielded considerable morbidity and mortality data for the specific diseases. So it includes collection of data, integration of data, analysis and interpretation, surveillance of the products and taking the action, dissemination of the information, then system evaluation, and it goes like a cycle. And we have formal and informal agencies to work on that. WHO, collaborating centers and laboratories, epidemiological training networks, military laboratory networks, global public health intelligence network, internet discussion sites, media, press, non-governmental organizations, NGOs, WHO regional and country offices, national public health authorities, UNICEF, UNHCR, and their country offices. So we have lot of formal and informal agencies who are working for the epidemiological surveillance data. Next, we have other health service records. Apart from hospitals, records can also be maintained in some other areas also. The first example is the records being maintained at the primary health centers, that is the PHCs, and the other ones are the polyclinics, then maternal and child health centers, school health records, the records that is being kept in the Anganwadis on birth weights, weight, height, arm circumference, immunization, etc., which are all available for uh, reference and research. Then special clinics like diabetes clinic, autism clinics, cardiac clinics also keep special specific records which can be used for the said purposes. Now we have environmental health data. Sometimes information on environment may be needed for studying the effect on health. This data is then required on various aspects of air, water, noise pollution. The impact of climate change on various aspects is a very good example of environmental health data. Then harmful food additives being used, the industrial toxicants, inadequate waste disposal and other aspects. Collection of environmental data remains a major problem for future research as well. Then we have health manpower statistics. For planning, administration, and evaluation of health services, information of health manpower is important. Such information includes a number of physicians by their age, sex, specialty, and place of work. That is, the manpower who are involved in the health service. then the dentist as the said earlier said classification, then the pharmacist, number of veterinarians, the hospital nurses, the vets, the medical technicians, all these data has to be made available. So the Ministry of Health and Family Welfare, Government of India, publishes every year the statistics data as Health Information of India. So the Institute of Applied Manpower Research attempts to estimate the manpower, and Planning Commission is also supporting for the cost. So their records are maintained by the state medical or dental or nursing councils and the respective directorates of medical education. So the census also provides information about the occupation as well. So this planning commission, as I said earlier, also gives estimates of active doctors for different states. So regarding medical education, statistics of number admitted, numbers qualified are given every year under the health information of India published by the Government of India under the Ministry of Health and Family Welfare. Now we have population surveys. Health information from the sources discussed in the previous slides do not provide information for all the diseases prevalent in and the health status of the community. So the statistics regarding diseases prevalent in the community and the health status of the community are of public importance and are very important for the public health administration. So also for research in any one disease or health related state, one may not find the required information in all these said records. So for that, we need specific health surveys. These health surveys are used for studying any aspect of health like mortality, morbidity, the nutritional status, etc. So survey for studying the diseases in a community is known as the morbidity surveys. So there are different types of health surveys. As you know, survey for studying the diseases prevalent and the distribution in the population and the health status of the individuals. These are known as community diagnosis. Then surveys to identify the health and risk factors. Then surveys for assessing the nutritional needs of the population, administration of health services, example the utilization rates, out-of-pocket expenditure on health, unmet health needs, etc. So there are different types of cross-sectional or longitudinal surveys, descriptive or analytical or both type of surveys, etc. So these can be done either by health examination or by face-to-face interview or by maintaining the health records or mailed questionnaires. So all these are possible to collect data from the population regarding the health aspects. So in India, NSSO, National Sample Survey Organization, is very active in conducting interview surveys. These surveys have yielded nationwide data in generating the morbidity, family planning and vital events. But the morbidity data is not that much reliable because of the limitation of the interview method, but still they were considered to be the standard sources of collecting the data. So similarly, as I said earlier, we have health records, then use of questionnaires, the size of the sample, everything has to be maintained. Then the regular health surveys in India include the Registrar General of India's annual health survey, National Sample Survey Offices, then National Family Health Survey reports, DLHS reports. So International Institute of Population Sciences Mumbai is a nodal agency for collecting both these population surveys. And other routine statistics related to the health are demographic, economic, social security schemes and for other data. Apart from the health, we also need data for these mentioned areas also. Demography means in addition to routine census data, statistics on other demographic phenomena such as the population density, movement, migration, educational level can be determined through this data. Then consumption of tobacco, dietary fats, domestic coals, sales of drugs and remedies, information concerning the per capita income, employment, unemployment data, everything can be coded. Then medical insurance schemes make it possible to study the occurrences of the illnesses in the insured population through the social security schemes and other data, which includes sickness absence, sicknesses and disability benefit rates, etc. Then we also have non-quantifiable information, that is information on health policies, health legislation, public attitudes, program procedures and technology. So health planners and decision makers require a lot of non-quantifiable information also on these areas for getting better health policies and legislations for the sake of the public benefit. So I hope I am clear to you. Thank you.